It was a superb end of week and weekend in Chicago at the great debates in GI oncology. I was delighted to see how much engagement there was, both from the speakers and the audience. And I was honored to give an update on the treatment of primary liver cancer or hepatocellular carcinoma. I always jokingly say that, hepatocellular carcinoma did not have much of presence beforehand because we didn't have therapies. But it's incredible to see how much of new therapies do we have these days. And enough that there's really continued debate about how to best to do things. During the talk that I presented on Saturday, I made sure, as always, ensure, number one, that we always do a biopsy, because otherwise we cannot confirm the disease. And number two is we will not understand the genetic makeup of the disease. And third, and very importantly, the LIRAD diagnostic approach radiologically, as we already know from LIRAD itself, was never tested in metastatic disease. So definitely biopsy is needed. The other second point that brought up is regard to liver function and the criticality of ensuring that when we look at the patient with liver cancer, to look at not only their cancer stage, but also at their liver function per se. And the Child-Pugh scoring has been really the most dependent on scoring system that we use. From there, we jumped on to talk about the different therapies. And as in our early chit-chat about this, yes, combination therapy is where things are going at the moment. We have that have proven to be effective and provide improvement in survival, to, of course, great responses and good tolerance or appropriate tolerance, which are the Atezolizumab plus Bevacizumab and the Durvalumab plus Tremelimumab. Spoke quite a bit about, the comparative components of those, even though they were never compared together. But always the message is making sure that when we look at the clinical trial, don't just read the numbers, look who are the patients. Because we know very well that now across the board, and actually many questions were brought up during the meeting on Saturday about knowing that Hep B patients will fare the most in regard to the use of checkpoint inhibitors, followed by the Hep C, followed by the non-viral. And interestingly, any of those studies, if they are really heavy on Hep B patients, they will fare way better than you thought. But if we were to really regroup all of this together, maybe the median survival, after all, for the use of checkpoint inhibitors plus another either anti-angiogenic or another checkpoint inhibitors is around 15 to 16 months. That's really what the norm is. That was based on many studies and many data that was presented, among which, of course, to begin with, the Hep B heavy AMBRAVE 150, the real AB of the Atezolizumab plus Bevacizumab, that was real world data analysis from the UK, and of course the Himalaya study as well. We spoke quite a bit about second-line therapies and the many options that are available. Also, it was nice, a question was brought up about the use of the first-line therapies after the checkpoint inhibitors combinations, like, for example, Lenvatinib or Sulfatinib as second line. And by all means, this really makes sense. This is really where the kind of most agreement is at the moment. We definitely touched on the sadly the studies as well and try to reflect why, and among which we spoke about the Cabozantinib plus Atezolizumab. And understandably, here there was two components. One of them is mechanistic component that probably the anti-CMET, anti-AXL might not be necessarily a driver into the cancer immunity cycle. And number two, of course, in regard to the PFS not being the right primary endpoint for studies of that nature. And the other one, which was a little bit more puzzling, is the Lenvatinib plus Pembrolizumab that, again, was negative, but surprisingly, the mean survival of the placebo plus the Lenvatinib was 19 months, which was kind of rather more than expected per se. And bring a lot of questions about why is that? Is there any anti-FGF enhancer that may be dependent in regard to the first-line therapy? Is it because of the therapies that patient might have gotten as second line? We're waiting for the data to be presented in in the manuscript format so we can learn more. But however, jokingly, at the moment, as we all know, we call this study the most negative, most positive study ever, because it really showed surprising words in regard to the Lenvatinib plus placebo of 19 months or so. So I would say it was a great delight. Good to see all colleagues and friends after a long time being on virtual. It was a delight to be in Chicago. And at the same time, it's nice to see that, most importantly, the biggest winner from all of this are the patients. More access, more therapies, more options. Nonetheless, I brought it in the meeting, and sadly, this is a reality that we're all responsible for. We have to understand that those therapies are only available for a very limited number of patients worldwide because of access issues. And realistically, the fact that there's still close to about 85% of patients in the continent of Africa that has the highest incidence of liver cancer in the world still don't have access only to sorafenib, make us pause. So hopefully we'll have a hand-in-hand approaches that we can find together how to ensure that therapy is available for everybody wherever they are. Again, I thank you very much for inviting me for this, and it's always a great delight. And hopefully we'll look forward for more interactions, being on great debates or, of course, other opportunities. Thank you very much.